press in the green button, share.
Yeah, I pressed the green one.
Yes, and then it will give you
Okay.
multiple windows.
Okay.
So you choose one of the presentation, or you can
Welcome,
choose
welcome, sir.
Professor Shahzad. Okay.
Hello,
Hi,
everybody.
Professor.
Welcome, sir. Hello, sir.
Hello, Sohail.
How are you, sir?
Assalamualaikum. Assalamualaikum.
Islam, sir.
So,
Salam.
Ahmed, this is my first time attending this. How are you going to run this?
I will.
Also, I'm trying now, but it's still not working.
We can hear you, Ahmed.
Sir, he's stuck.
Hello, sir.
Okay, second. Computer audio, slide as background, portion of the screen, advance, document. Let's check it.
Dr. Ahmed, should we start?
Yes, she said, sorry, I have some problem with the connection.
Yeah, I'm just trying.
Okay. Did sharing work with you, Dr. Ahmad?
I'm trying now, but I guess Professor Prakash can start. Oh,
Okay, we will start with him.
okay.
I was meaning
Okay.
to just do a test, so don't.
Yeah.
So, okay, Dr. Prakash.
Okay.
So, Professor Shahzad, guys, you can start welcoming the audience and introduce our program. And then Dr. Prakash will.
Yeah.
Is
it visible?
Yes,
Yes,
sir.
you can make it
Yes, sir.
full screen. Yes, perfect.
Okay.
Should
So good
we?
evening from Nepal and respected
So,
chairperson, moderators, and all the audience and the webinar. So I would like to bring a warm welcome to you all from Nepal. And today my topic will be like brainstem nuclei, its motor function, motor and
Dr.
autonomic.
Prakash,
Yeah.
sorry for the interruption. Dr. Shahzad should first start welcoming the audience,
Okay.
and then he will introduce you and Dr. Suhail, and after
Yes.
that, Dr. Suhail introduce you to start. Okay?
Okay, sure.
Okay. It's all up to you, Dr. Shahzad.
So, first of all, welcome everybody to this session. We are very grateful to all the collaborators who've made this possible. And I am especially grateful to Ahmed, Imadullah, Moaz, to make this session possible. I would like to introduce the first speaker, Dr. Prakash Kafle. Dr. Prakash is a professor and head of department at the Nobel Medical College Teaching Hospital. For those of you who haven't been to Nepal, Nobel is a beautiful teaching hospital in the outskirts of Kathmandu and in the middle of very beautiful mountains. I've been there and very good memories of that place. So Dr. Prakash is going to talk about brainstem nuclei, sensory, motor, and autonomic functions. So please proceed, Dr. Prakash.
Yeah, thank you, Dr. Samim and all the moderators. And so it's my great opportunity to talk and be in touch with my friend Ahmed always. I feel very great and it's my humble. So I'll be talking about this brainstem nuclei. Brainstem nuclei is a very vast and complex topic, but I have tried my best to make it as simple as possible. So for the beginners, as we all know that this is a brain where this is the part of the brainstem. So it is like covered by from posteriorly by this huge structure cerebellum. So this is the part from midbrain up to the this is connecting the whole diencephalic part to the spinal cord. So we'll be discussing about important structures in the previous sessions. My fellow colleagues, they have already talked about different parts of the brain and different anatomy of the different parts of the brain like midbrain, bones. And my friend Moaz is supposed to talk about medulla. I think he will talk after this session. So let me proceed with this thing. So before going into the internal structure and architectures about the brainstem, we should know about the external architecture of the brainstem. That is, this is the anterior part of the brainstem, where this is the midbrain, and this at the superior and inferior colliculus level, and this is the pons, and this is the part of the medulla. And the same part what we see is it is a cut open of the cerebellum, and the cerebellum has been removed off, and so we see the this rhomboid fossa lay open, and where we can see the superior cerebral peduncle, middle cerebral peduncle, inferior cerebral peduncle, and the obex, and this is part of the medulla, right? So this is midbrain seen from the posterior part, and this is the pons, and this is the medulla. And similarly, if we see this midbrain from the lateral view, we see this is the anterior part, this is the posterior part, and this is the lateral view of the brainstem. So before going to see the nuclei of the brainstem, we must review some part of the embryology, how the nervous system develops. As we know, during the developmental stage, at the 4 weeks of life, what happens? The important structures, the sulcus limitans. This is the figure which is showing the transverse cross section of the this embryonic this neural tube at the age of 4 weeks, right? Here, what happens? When this structure grows, the sulcus limitans depends and divides the neural tube into the two plate. One is the alar plate, another is the basal plate. What happens? The alar plate becomes the develops into the sensory neurons and sensory nucleus, and this basal plate or basal plates form the motor nucleus, and which resembles the ventral part of the spinal cord like structures, and this alar plate resembles the dorsal part of the spinal cord like things. So you see here, this is the midline and this is the sulcus limitans, and whatever things are there during the development, this area, it is formed by this basal and motor nucleus, and beyond this on the lateral part it is formed by the they form into the sensory nucleus. So this is the alar part and this is the basal part. And if we see in the cord section, what happens? This is formed by tectum, tegmentum, and the base, where there will be the cross cerebri and substantia nigra at this level. One thing what we have to know is all the basal nucleus, this brainstem nucleus, they are located in the tegmentum. You see at the level of midbrain, the tegmentum occupies this area, okay? This from this cerebral aqueduct up to this interpeduncular area. If we go down, then the tegmentum comprise of this whole area. But if we see the medulla, the whole part of this area is comprised of tegmentum. So all these area, this tegmental area contains the brainstem nucleus. This is the gist. So now if we go to the brainstem nuclei, what we think that the motor nuclei, they are located more medially. So this is the midline structure. All the somatic neurons, if we see from longitudinal path 3, 4, 6, and 12, they are always in the alignment like this. They are in the same line. And lateral to this, there will be the brachial motor nucleus. They will be aligned in this, like 5, 7, 9, 10, and 11 here. And again, lateral to this will be the visceral motor nuclei, like 3rd, 4th, 11th, 10th. Okay, 9th and 10th. And after that, there will be the more laterally, there will be all the this sensory nuclei are located. This topographical location helps us to localize the lesion. So it becomes like the motor nuclei has gone, then our localization will be this much. Sensory nuclei are gone, then our localization will be gone, and localization will be done. So sensory nuclei helps us in localization of the lesion. So we all know that this is the cranial nerve. 1 to 8 is a pure sensory, where 1 and 2 are not discussed today. We are not going to discuss about the olfactory and optic. Beyond, from 3 to 12 we will be discussing. So we classify this brainstem nuclei as motor, sensory, and autonomic, as I have told in the last slide. So if you see the dorsal part of the brainstem and cranial nerve nuclei, you will see this is the more medially will be the red line will be the motor part, and the blue line will be the sensory part. So they run in a longitudinal fashion from top to bottom, from midbrain, pons to medulla. And if we see the gross anatomy of this brainstem, which my friend will be discussing, this is important. There are some important landmarks while we discuss, like at the level of the superior colliculus, what are the nuclei? At the level of the inferior colliculus, what are the important structures and what are the nuclei? And the level of the midpone and lower pone, and the upper medulla, mid medulla, and the lower medulla. So these are the most important landmarks in the either for surgery or for the localization of the nucleus, right? So what we see is this is the schematic diagram of this brainstem nuclei. I'll be discussing about all the nucleus separately, but this is for general view. In the midbrain, we are worried about the 2 nuclei, 3rd and 4th. So at the level of the superior colliculus, there will be the 3rd, and at the level of the inferior colliculus, there will be the 4th nerve nuclei. So 4th nerve nuclei is the only nuclei which, like winds, exits from the ventral dorsal part and in anterior part and goes to the dorsum and exit from there. So this is one of the peculiar nerve. And after that, there will be like 5th nerve. 5th nerve is the hero of this brainstem, you know. All this, it has many nucleus, and it has nucleus in the midbrain, pons, and medulla. So it is one of the hero of the brainstem, though there are other as well. And similarly, this is the abducens nerve, this is the vestibulocochlear nerve. It is in the upper medulla as well. And this is the trigeminal nerves, and trigeminal has 3 nucleus for sensory and others as well. And this is the part of the this upper medulla where all these vestibulocochlear are located. And this is the part of this medulla again, where the dorsal motor of the vagus nerves, hypoglossal, all are in this area. So in the medulla, I already told that whole of this part will be the tegmentum. So this all area, this tegmentum contains all the parts of the nucleus. And these are the groups of motor nuclei which we see. And these upper 4, oculomotor, trochlear, abducens, and hypoglossal, they are the pure motor. 3, 4, 6, 12, they are the pure motor nucleus which are in the first midline. And these are adding this Edinger-Westphal nucleus, superior olival nucleus, inferior olival nucleus, and the dorsal nucleus of the vagus. These 4 nucleus are accessory motor nucleus which are in the lateral side of the lateral other than the main part. And this trigeminal motor, facial, and ambiguous, they work in common. Mainly ambiguous nucleus ambiguous is associated with, and it acts with combination with the 9, 10, and 11 nerves. So these are the pure motor nuclei of the brainstem. And what about sensory? The sensory nuclei in the brainstem process afferent information. They carry the general somatic afferent like pain, touch, and temperature. Special somatic afferent, they are responsible for hearing and balance. They are more laterally, and the visceral afferent will be in the middle of this general and the special somatic somatic afferent. So special somatic afferent, this part will be the most lateral, as we saw in the second slide in the photo. And they are located in the brainstem due to their topographic in the this embryonic development. So this group of nuclei are purely the sensory nuclei of the brainstem. Here, this upper three, this mesencephalic root, principal sensory root, nucleus of the fifth, and the nucleus of spinal tract, they are all associated with the fifth cranial nerve, right? But their afferent will be different. So I'm not talking about this afferent tracts. And other is this nucleus of solitary tract and the tractus, this rostral part, and the nucleus of the solitary tract caudal part, they have different location. The rostral part is located in the pons, whereas the caudal part is located in the medulla. The thing is, the rostral part carries the taste sensation of the tongue, taste sensation from tongue by 7, 8, and 7, 9, and 10, whereas the caudal portion carries the general sensation by cranial nerve 9 and 10th. And other two sensory nuclei are vestibulocochlear nuclei, and they carry the this cochlear is responsible for the auditory things, whereas vestibular nuclei is responsible for the balancing. So auditory part is especially by come fiber from the spiral ganglion, whereas the vestibular fibers comes from the Scarpa's ganglion. Why same cranial nerve say 8. So talking about the trigeminal sensory nuclei, as I already told, it is the hero of the brainstem. Trigeminal sensory nucleus has three parts. One is mesencephalic nucleus, which is responsible for the proprioception from the jaw, and the chief nuclei or the principal nuclei of the trigeminal nerve, which is also called the chief principal nuclei of the trigeminal nerve. It carries the touch and pressure sensation from the face, and the last nucleus, the spinal trigeminal nucleus, carries the sensation of pain and temperature. So it receives cranial nerve 5, 7, 9, and 10, and it projects to the ventroposterolateral nucleus of the thalamus, as usual in the other sensory pathway. Now talking about the solitary nucleus and the visceral sensation. The nucleus of solitary tract, it receives the somatic visceral afferent in the taste, as I told, from the 7, 9, and 10 from the tongue, and the this GI, this visceral sensation from the thoracoabdominal organs. So they are vital for autonomic reflex, baroreceptor reflex, chemoreceptor reflex, and the GI reflexes. And they again project to the hypothalamus and thalamus and the reticular formation area. If we see in the cross section at this level, at the pond, then this is the nucleus of facial nucleus, and this is the superior salivary nucleus. So it winds around this thing, abducens nucleus 6th, and come out of the brainstem. So this is of clinical importance. Whenever there is any pathology of the 7th cranial nerve, patient will also have the issue of 6th as well. Another is vestibulocochlear. This, if we see in the picture, this is the cochlear and this is the vestibular nucleus, and they wind around the middle. They come medial to the middle cerebral peduncle, this inferior cerebral peduncle, and exit the brainstem. So this is the cochlear and this is the vestibular part of the brainstem. Cochlear, this is the vestibular. So the clinical correlation will be whenever there is sensory deficits, system may be, the pathology may be trigeminal neuralgia and Wallenbach syndrome or lateral medullary syndrome, vestibular dysfunction, or glossopharyngeal neuralgia because of this involvement of the different roots in the lateral part of this bones. So coming about the motor system, the key concept is motor nuclei give rise to the efferent fibers that innervate muscles derived from the somates. They are located medially in the brainstem due to the embryological original development, and the two main categories are general somatic efferent and the special visceral efferent. Now coming to the motor nuclei, purely 3, 4, 6, and 12 and 11 as well. So if you see, so this is the central aqueduct, and this is the Edinger-Westphal nucleus, and this is the again third knob nucleus. Okay, so at the level of superior colliculus, the this knob will be third knob nucleus will be here, Edinger-Westphal nucleus, which is also called as a accessory oculomotor nucleus, lies just adjacent to the this oculomotor nucleus. And here at the superior colliculus level in the midbrain, the important thing is the red nucleus. this is the red nucleus. The third nerve passes through the red nucleus here. The importance of this thing is the red nucleus is one of the most important nucleus in the extrapyramidal system, which connects this basal ganglia superiorly, cerebellum laterally, and the spinal cord inferiorly. So it plays vital role in the movement. Any destruction and the also in the this herniation syndrome, if any destruction is or distortion is above the red nucleus, the clinical feature will be different. If the herniation is below or at the level of red nucleus, the clinical feature will be different. So red nucleus is a very important structure at this superior colliculus level, right? Now, if we talk about the midbrain cross section at the level of inferior colliculus, then we see this there are the fourth nerve nucleus. This fourth nerve nucleus, what happens? The left fourth nerve nucleus lies on the right side of this brain, and the right cranial nerve nucleus, fourth cranial nerve nucleus lies on the left side of the brain. So the clinical feature, though not that significant in day-to-day practice, is that if there is a right-sided fourth cranial nerve nucleus, the pathology will be different, and patient will have a pathology on the symptom on the left because of left cranial nerve fold palsy, and vice versa. So the oculomotor and trochlear, they are associated with the controlling extraocular muscles. As we know that all the muscles are supplied by third nerves except superior rectus and superior oblique and inferior lateral rectus, right? So this oculomotor nerve is will control the four muscles along with the levator palpebrae superioris muscle, which helps in the elevation of the eyelid. Whereas the trochlear muscles will be controlling the innervates the superior obliques, which helps in the person to look downstairs. Now coming to the facial and trigeminal motor nuclei. The facial nuclei is located in the caudal pons. You see here. Okay. So this is the this sixth nerve, and here is the another is the fifth. Okay, seventh. So this one is the seventh. So this part is seventh motor nucleus of seventh nerve, and this is the motor nucleus of this abducens nerve. And this facial nucleus is located in the caudal pons. It innervates the muscle of facial expression, and the upper face receives the bilateral cortical inputs, whereas the lower face receives the contralateral only. You see in this picture, what happens? So in this upper part is innervated by both ipsilateral this facial nerve as well as the contralateral facial nerve, but the lower part is innervated by only the contralateral part. So the clinical features of supranuclear lesion or the lesion above this nucleus and this facial nucleus, and the lesion below the facial nucleus, the clinical feature difference. As in Bell's palsy, what happens? There will be the disruption of the facial nerve below the nucleus. So the patient will have this palsy on the same side, and the face the stronger part pulls the face toward the strong part or normal side. Whereas in case of this upper motor neuron type of facial palsy, like in supracerebral, like in brain stroke, what happens? It controls the opposite side, so that the opposite side of the lesion will have the facial palsy. However, the patient will have the facial deviation toward the same side of the lesion. So this is the difference between the lesion of supranuclear and the infranuclear. And talking about the trigeminal motor nucleus, it is located in the midbrain again, and it innervates the muscle of mastication, and it is involved in the jaw reflex. So talking about the abducens and hypoglossal and accessory nerve nuclei, we see abducens nerve nuclei. So this pink color area, so this is the abducens nerve. So the abducens nuclei will be here, medial to the main sensory nucleus of the cranial nerve 5. Okay, here. And talking about the accessory nerve nuclei, this accessory nerve will be in the spinal cord in the upper part. and this is the part of the nucleus ambiguous where they work together in combination with the 9, 10, 11, 9, 10, and 11. So this is the spinal accessory nerve. And this is the hypoglossal nerve. And this hypoglossal nerve will be the most medial. It will be more medial to the vagus nucleus. If you see the this rhomboid fossa, the inferior most part, just lateral to the area postema, there will be the dorsal nucleus of vagus. Okay, so medial to this will be the hypoglossal nerve, and it exits through this way. So what happens is this abduction nerves innervates the lateral rectus muscles, and it is a part of horizontal gaze central and connected by MLF. What happens if MLF is involved, the gaze pulse will be there. If only the abduction nerve is involved, then the there will be the issue on the these muscles. And the accessory nucleus is, it arises from the upper cervical spinal cord, and it innervates the sternocleidomastoid and the trapezius. And the talking about hypoglossal, it is located in the medulla, I already told, and it is near the midline, this one, and controls the intrinsic and extrinsic muscle of the tongue. And whenever there is a hypoglossal nerve injury, what happens because of the vector issue, this tongue again deviates to the same side. It is because the weaker part cannot hold, and the strong part, muscle bulk, will go toward the weak side. Another nucleus of interest is nucleus ambiguous. You will see this is the nucleus ambiguous nucleus. This is the inferior salivary nucleus. These all are located in the medulla, and it is it innervates the muscle of the soft palate, pharynx, larynx, and they are essential for swallowing, phonation, and speech. And the clinical importance is if there is any lesion on this part, then there will be dysphagia, dysarthria, hoarseness, and this is also involved in the lateral medullary syndrome when there is infection. So clinical correlates, as I told, whenever there is ocular palsy, there will be the ptosis and eye deviates down and out, as we see commonly in case of hydrocephalus or any brain herniation syndrome or any uncal herniation, or because of any this Thornau palsy, whenever there is aneurysm like posterior communicating artery aneurysm compresses the ocular nerve. And similarly, the Bell's palsy, I have already told, and the hypoglossal lesion, the tongue deviates toward the same side of the lesion, and the nucleus ambiguous, as I told, there will be hoarseness, and patient has a high risk of aspiration and choking. And the lock-in syndrome, there will be a bilateral ventral pontine lesion and sparing the gaze. So the autonomic nucleus, the general overview is these nucleus are involved in the visceral motor, mainly the parasympathetic. They are found in the midbrain, pons, and medulla. They contribute to pupil constriction, glandular secretion, especially this mandibular and submandibular parotid secretion, and cardiovascular and respiratory regulation, GI motility. And these important autonomic nuclei are Edinger-Westphal nucleus, superior inferior olivary nucleus, dorsal motor nucleus of vagus, and the nucleus ambiguous. Of these 4 tracts, I'll be discussing in brief about this Edinger-Westphal nucleus. It is very important. It's because it is related to light and accommodation reflex. So it has preganglionic parasympathetic fibers to ciliary ganglion and innervates the pupillary sphincter muscles and the ciliary muscles. They are responsible for light reflex and accommodation reflex, and they are involved in these both reflexes. So if we see that this is the light source coming on the light from the retina, and it goes to the optic nerve, from biretina to the optic nerve and optic chiasma, and to the some fibers goes to the lateral geniculate body, and some fibers go to the pretectal nucleus. Those fibers which go to the lateral geniculate body, they are transmitted to the this occipital cortex, and from there they are diverted to the frontal eye field area, so that whenever there is any lesion in the frontal cortex or in the extra pretectal area, then the accommodation reflex will be lost. Whereas if there is lesion in the pretectal area, there won't be accommodation, but light reflex will be there. But whenever there is a lesion in the Edinger-Westphal nucleus or in this pretactal nucleus or in the oculomotor nucleus, then there will be no light reflex. As we see in the syphilis, where there will be loss of accommodation, like we call Argyll-Robertson pupil. So this is associated with this thing. And the dorsal motor nucleus of vagus. So again, this is the dorsal motor nucleus of vagus, and this is the hypoglossal nucleus. As I told in the previous slides, it is located again in the medulla, lateral to the hypoglossal nucleus. So its function is parasympathetic innervation to the thoracic and abdominal organ, like heart, lung, and GI tract. So it works in the concern with the nucleus ambiguous, and its lesion causes impaired autonomic function, that is called dysautonomia. So it is also a target for this is modulation surgery nowadays. Now periaqueductal gray and autonomic integration. The main function is the midbrain structures surround it. It is located around the midbrain structure surrounding the cerebral aqueduct, and it integrates autonomic and behavioral response to stress, pain, and the fear, and it modulates pain by descending inhibitory pathway and project to the nucleus raphe. And it is also of clinical importance. It is because it is the site for opioid action and the target for neuromodulation in chronic pain and autonomic disorders. And the clinical syndromes associated with this autonomic dysfunction are Horner syndrome, autonomic dysreflexia, central sleep apnea, and vagal overactivity, which may be danger and leading to bradycardia and syncopal attack, right? So another important topic and the center in the brainstem is central pattern generators, which is known as CPGs. And these are the neural circuits that generate the rhythmic motor pattern like breathing, chewing, walking without sensory feedback. So they are located in the ventral area. So this is the area for the Boginger's complex. So this pre-Boginger complex is responsible for this central pattern generators. So for respiratory central pattern generators, this pre-Boginger complex is of more important, and swallowing and sucking centers are nucleus tractus solitaris and adjacent reticular formation. So brainstem stroke may affect this area, CPG's area, and patient may end up with multiple brainstem syndromes. So it is of more important. And nowadays, with the imaging technology and advancement in MRI technology, we can localize the brainstem nuclei and note the destruction and can prognosticate along with the diagnosis value. So we can do high resolution MRI and to look at the focal infarct, to know the tumor and the destruction of the tracts, and also know about its demyelination status. So the functional MRI also shows the brainstem activation pattern, and other like DTI, diffusion tensor imaging, will visualize the white matter tracts and their disruption. So these all new MRI technology help in planning the surgery. So it gives the clinical insights like advanced imaging can detect the microstructure damage basically in brainstem surgery. So there are this knowing the location of brainstem nuclei helps in proper planning of brainstem surgery. It's because brainstem surgery is very much challenging, and whole structure and all white matter fibers, they are passed through brainstem, and a single mistake or single destruction and discontinuation in the tract may lead to a moribund life. So morbidity will be high. To prevent this, all this neuroimaging and safe brainstem entry zone should be known. So these all idea and knowledge of brainstem nuclei helps in choosing the right trajectory for brainstem surgery. So now emerging imaging technology like 7 Tesla MRI or functional MRI PET will help for the diagnosis. And now there is also a role of AI intelligence like machine learning, and they are more helpful for localizing the lesion in the brainstem. So coming to the conclusion is brainstem nuclei are organized into sensory, motor, and autonomic systems. Each cranial nerve nucleus solves specific functions, role, and integrated into the life-sustaining process. The clinical syndrome often reflect anatomical localization of affected nuclei and tracts, and advanced imaging and neuromodulation techniques now allow direct targeting of the brainstem structures. So a solid grasp of brainstem functional anatomy is crucial in clinical diagnosing, surgical planning, and the research innovation. So, my dear friend, I will also like to invite you to the Incarnation 5, which is addressed by all international neurosurgical bodies. It is on the November 13th to 15th. You are all welcome to the international conference in Nepal. Thank you.
Thank you, sir. Very nice and excellent talk by Dr. Prakash Saab. We are coming to the audience. Anyone from the participant need to ask any questions, or he can drop in box. Any questions from the audience? Very nice and excellent talk by Dr. Prakash.
Thank you, Dr. Amal.
We are coming to the audience. Anyone from the participant need to ask any questions, or in box, or drop in box. Any question?
No question till now.
So shall we proceed to the second speaker? Can we have Dr. Moses' slides uploaded, please?
Yeah, I'll discontinue the sharing.
Thank you very much, Dr. Prakash, for a very,
Yeah.
very lovely talk on the brainstem nuclei and the function.
Yeah, thank you. It's my pleasure. So I'll
I have
stop
to once again mention your beautiful hospital in the valleys of Bharatnagar, which I had the pleasure to visit a few years ago.
Oh, okay, that's my pleasure.
Our second speaker is Dr. Moaz Mohammed, who also
Yeah.
comes from a center that I really, really admire, the Yeditepe University Hospital in Istanbul, Turkey. Now, Yeditepe means 7 hills or 7 mountains, and this is the name often given to Istanbul. And this university hospital is also a state-of-art place where, again, I had the pleasure to visit and also attend a few of the cases in the operating room. Dr. Moaz Ibrahim Abdullah is an assistant professor of neurosurgery and neuroanatomy and a fellow at this university hospital, and he will be talking about cross-sectional and surface anatomy of medulla oblongata. So welcome, Dr. Moaz, and thank you very much for doing this.
Thank you very much. Yes, sorry, I'm trying to share my presentation. I guess I have some technical problem.
We can see your slides. You can maybe if you could, you can switch on slide sharing.
Okay.
You know, Kumar, if you can stop sharing, and then you can share again,
Okay.
and you choose the screen of your computer screen. You choose the computer screen, and then anything in the computer screen we can see. It will be, I think, it will be easier.
Yeah, okay.
Choose the screen sharing, and then in the
Is it
you
shared
have
now?
multiple windows. Yes, but we see you and
Now
your
it is
screen.
shared.
We don't see your computer screen.
Ah, okay.
So when you do screen sharing, choose from the screen that you have, choose screen, entire screen. Choose the entire screen, and then we can see your computer screen as it is. Please stop sharing and then share again.
Okay.
You can try now. Press in the share button and then you choose the entire screen.
In progress.
Come on, can you hear me?
I think there is a connection problem.
Maybe. Fuad, can you hear me? I think, yes, you can. Okay. Dr. Muad.
Not is mute.
Can you hear me, Dr. Muad? Yes, that's perfect.
It's
You can
perfect
now,
now,
please,
Dr. Moaz. It's perfect.
please choose the presentation mode, please. Yes. Yes, perfect. That's perfect. We cannot hear you, Dr. Muad. The screen is perfect, but we cannot hear you.
Dr. Moaz, you're on mute.
Please check your microphone, Dr. Muad. Dr. Muad, do you hear me? It's good. The screen sharing now is good, but we cannot hear you. I don't hear what you say. Dr. Muad,
Dr. Moz is still mute.
Dr. Maad? Can you hear me, Dr. Maad? We cannot hear you. Please check your microphone.
Okay. Hello? Hello. Now my voice is clear?
Yeah, good now.
Okay. Okay, now it's good.
Yes,
No,
perfect.
clear.
Make
Clear.
it in full screen.
Thank you. Sorry
Press
for the
presentation mode.
yeah, okay. Thank you for this
Yes,
delay.
perfect. Now it's perfect.
Yeah, hello everyone. And thank you for this kind invitation. I will try to show very briefly the external feature and cross anatomy of the medulla oblongata. Just I will start here with the historical aspect. So when we mention the medulla oblongata, we have to remember the Herophilus of Chalcedon. The Herophilus of Chalcedon is the father of microneurosurgery. So Chalcedon is a modern day Kadikoy. Kadikoy is a city in Istanbul where I'm living now. And from here also, I want to send a special thanks to Professor Abuzer and Professor Toure for giving me a nice chance to participate in this fellowship. So the Herophilus start searching the soul of human. And he said the soul of human is located in this area, the blue area. And called this area is Calamus scriptorius. So Calamus means the reed pen. At the ancient time, when you used to write everything, so they call it reed pen or Calamus scriptorius. When we came to the external feature of medulla oblongata, I will try here to show my own dissection, which I did here in Yeretebe laboratory. So as Professor said before, I will just remind, the external feature very briefly. As we know, the brainstem consists of main three structures: midbrain, pons, and medulla oblongata. Midbrain separated from pons by pontomesencephalic sulcus, and you have third cranial nerve here, emerge at the level of superior colliculus, and you have fourth cranial nerve emerge at the level of inferior colliculus coming from back, and you have here trigeminal nerve located in the mid pons, comes out and anterior lateral to the pons. When we come here to medulla oblongata, okay. When we come here to medulla oblongata, we know that the medulla oblongata is starting here at this point, at the between the pons here, at the level of pontomedullary sulcus above, and down here at the level of pyramidal decussation here. So this pyramidal decussation at the level of first cervical root. The importance of this point, because the all tracts at this point it change their direction. So it's important to know where is the lower limit of medulla oblongata. Here we have the median sulcus. Just lateral to median sulcus, we have these two important structures here, the pyramid. Above the pyramid, there is the pontomedullary sulcus, and lateral to it, we have 6 cranial nerve emerge here. Lateral to pyramid, we have this oval structure, the olive. Between the olive and the pyramid, we have anterior olivary sulcus, in which the 12 cranial nerve, hypoglossal nerve comes out here, between the pyramid and olive. Just superior to olive, we have the supraolivary sulcus, in which 6 cranial nerve, as we mentioned, appear, and 7 and 8 cranial nerve here in the supraolivary sulcus. This lateral view showing the posterior part of the olive. In the posterior part of the olive here, we have posterior olivary sulcus. This area for me is very important area, located between the olive and the lower cranial nerves, 9, 10, and 11. Because in this area here, we find, when we dissect this area, we will find a lot of tracts. The most important tract is ventral spinocerebellar tract. And we have also spinothalamic tract. So all anterior lateral system is located here in this area. It's not just like a posterior olivary sulcus. So if we see here, as I mentioned, we have a pyramid, olive, 6, 7, 8, and lower cranial nerves. In this area, just lateral to lower cranial nerve, we have the inferior cerebellar peduncle is located here. So if we put them in order again, we have the pyramid here, and here we have anterior olivary sulcus, we have the 12 cranial nerve emerge, then we have olive, then we have posterior olivary sulcus, and we have supraolivary sulcus here. Posterior to it, we have the Gower's tract, the ventral spinocerebellar tract, we have the spinothalamic tract, all of them located here. Then we have lower cranial nerve, 9, 10, 11 cranial nerve. Posterior to lower cranial nerve here, we have the inferior cerebellar peduncle. It has two faces. Here, the lateral part of inferior cerebellar peduncle, and also we have a posterior part. We will see it when we discuss the fourth ventricle. This one of my dissection. I showed here the 6 cranial nerve coming and going lateral to the corticospinal tract. Here is the corticospinal tract. Here is the 6 cranial nerve coming and going lateral to it and superior to the olive in supraolivary sulcus here. I start to dissect and I remove the lamina over the medulla oblongata on the lateral surface here. I showed here the corticospinal tract going down. Then I showed the anterior olivary sulcus and the olive nucleus, and I showed here this part of this tract. It's difficult to differentiate the ventral spinocerebellar tract from the spinothalamic tract, but all of them located here, just posterior to the olive. And also we have this very important structure, external arcuate fibers. External arcuate fiber originate from here, from the nuclei located anterior to the pyramid. We call them arcuate nucleus. This arcuate nucleus is the part of pontine nucleus. During embryology, part of this pontine nuclei descend down here and send the fiber through the external arcuate fiber to the cerebellum. So we call it external arcuate fiber, located just lateral to the corticospinal tract and lateral to the Gower's tract here. Also, we have here the dorsal spinocerebellar tract. Here, we have ventral here and dorsal spinocerebellar tract. It comes up and joins the inferior cerebellar peduncle to go to the cerebellum. Also the same, in this dissection, I showed here the external arcuate fiber, starting here. In the nuclei here, it's difficult to show it, but it originates from here, anterior to corticospinal tract, then going lateral and going up to the inferior cerebellar peduncle. Here we see the ventral spinocerebellar tract on the right side. It goes up and come down through the superior cerebellar peduncle, while the dorsal spinocerebellar tract going up and enter through the inferior cerebellar peduncle. Also, in this dissection, I removed the Gower's tract and ventral spinocerebellar tract, and I showed parts here of reticular formation fiber, or sorry, nuclei is located here. It's difficult to distinguish. And also just lateral to the ventral spinocerebellar tract. After I remove it, I show the spinal trigeminal nucleus. It's located here, if we follow it like this. We have the lower cranial nerve fiber, and also it's very obvious, the dorsal spinocerebellar tract going down and goes here to the inferior cerebellar peduncle. Fifth cranial nerve, also the same as I mentioned. In this dissection, I dissect the right and left side of the brainstem. And here, especially the medulla oblongata here, as I mentioned before. Here at this level, I showed the medial lemniscus up. Here I show the same pyramid, inferior olive. Here I showed the trigeminal nucleus here. This structure here is the central tegmental tract. Is wrongly, I wrote it, but here's the central tegmental tract. So central tegmental tract coming from the right nucleus down until the inferior olivary nucleus. In this side, in the right side, I showed this fiber is not clearly obvious, but this fiber is the olivary cerebellar tract. It's coming from the contralateral olive and going to the inferior cerebellar peduncle. It's here, olivary cerebellar tract. In this dissection, I removed the whole corticospinal tract. On the right side, I showed the medial lemniscus, as you see here. Medial lemniscus coming from the back from the cognate and gracile nuclei is decussate and coming up at the medial lemniscus going upward, continuous up to the thalamus. Also here is very obvious the inferior olivary nucleus. Also central tegmental tract is very obvious coming here. It's very important tract. And also here olivary cerebellar tract crossing up, and this is trigeminal nucleus. Here also I cut the eighth cranial nerve. I show this is the vestibular part of eighth cranial nerve, and this is small fiber here, the cochlear part of eighth cranial nerve. Here's the inferior cerebellar peduncle going up from the medulla. This is the dorsal spinocerebellar tract. Here the also join some fiber from occipitocerebellar, olivary cerebellar tract. Join here to form the inferior cerebellar peduncle. Here I cut it, I showed the dentate nucleus from posterior. If you notice here, the trigeminal nucleus coming down and goes just medial to the dorsal spinocerebellar tract here and emerges again here. So it starts from here. This is the trigeminal nucleus coming like this, and appear here again. Also, this very important tract is olivary spinal tract is going down here. Here's the C1. When we come here to the fourth ventricle, this is before dissection. As you know, the fourth ventricle, this area we call it rhomboid fossa. So it divided into two parts. The upper part formed by pons, the lower part formed by medulla. And here is the intermediate area. Mostly there is the stria medullaris located here in the fourth ventricle. The lateral border, we have the gracile tubercle here. We have the vestibular nuclei here. In the right side of this dissection, I remove also the lamina, and I showed all of them. If we come from up downward, we will see here first the facial colliculus. I just showed here the 7 cranial nerve going around the 6th nucleus, abducens nucleus here. Also, I showed here the superior vestibular nucleus. We have stria medullaris here. As the medulla here, we have hypoglossal triangle here. Just lateral to it, we have the vagus triangle. And this gray area is area postrema. Just between the area postrema and the vagal trigone, we have this structure we call funiculus separans. It's like a cord structure separating the vagal trigone from the area postrema. We have here gracile tubercle, we have cunate tubercle, and we have gracile fasciculus and cunate fasciculus. I showed all of them. On the lateral side here, we have this structure, is restiform body. So restiform body is the part of inferior cerebellar peduncle, contain most fiber of the dorsal spinocerebellar tract and part of accessory cuneatus nucleus tracts. Here we have dorsal cochlear nucleus here, located posterior to it. Also in this dissection, I showed also the same part of them. As we see here, this is a restiform body. We have here gracile nucleus. We have here cunate nucleus. The same. When we came to the cross-section anatomy of the medulla oblongata, the most common book that we use to get the anatomical information, for example, like the human central nervous system book, if we see this is a cross-section of medulla, and also the same. But when I start to dissect, Professor Torres told me very important things. When we start to study the medulla oblongata, we will see always the direction of the MRI is totally different from the direction of the box here. As we see, we will find here the pyramid is directed down, while in the MRI, the pyramid is directed up. So before we start dissection, first I change the direction in all the book of Riley. If we see here, I change also, I used Photoshop to change all this letter to be up like this, to be matched with the MRI, like a pyramid here and olive here. Then I start to dissect. Okay, in this cross section is lower down in the medulla oblongata at the level of pyramidal decussation. I cut this area. As we see here, the corticospinal tract like this. And this yellow area is just the decussation area, like here. Here, this yellow bar is correspond to the fasciculus gracilis is here. And this correspond to fasciculus cuneatus. Here, this area correspond to the to the trigeminal nucleus or spinal trigeminal nucleus here. Here correspond to the accessory nucleus, the spinal, to the cranial accessory nucleus is here. This cross section above at the level of sensory deconcentration or at the level of the gracile and cuneate. So as we know that the gracile fasciculus and cuneate fasciculus go up to the gracile and cuneate nuclei, then they form the internal arcuate fiber, then they go up as the medial lemniscus. So this section just below the deconcentration of the internal arcuate fiber, the same. Here's the corticospinal tract as here. Here's the lower part of inferior olive. Here's the medial lemniscus fiber going up as located here. And also the same nucleus of nucleus gracilis and nucleus cuneatus located here. Also the same is trigeminal tracts. This section at the level of mid-olive. I just cut the brainstem or the medulla at the level of mid-olive here. As we see here, the corticospinal tract fiber is the white fiber, as here. Also, we have here the olive nuclei, inferior olival nucleus. Also, we have medial lemniscus is located here. Here in this latter side, we have the ventral spinocerebellar tract or Gower tract with the spinothalamic tract is located here. Here located. Here we have the inferior cerebellar peduncle located lateral, as here is the restiform body, this section. And we have here trigeminal nucleus again, located here. The whitish area here. We have here vestibular nuclei, is just medial to the inferior cerebellar peduncle or restiform body, located here. We have here this red area. Red area here is the vagal trigone here. It's just a little bit lateral. And the most medial, we have hypoglossal nucleus is here, located here. This fiber tract we use usually for Professor Toure before operation, just to locate the tumor site, to locate the tumor site. For example, here's the tumor. Here's the whole fiber inferior, for example, here, inferior cerebellar peduncle going up. Also, here's the superior cerebellar peduncle, the pink one. The yellow one is the inferior cerebellar peduncle. The green one here is the middle cerebellar peduncle. The red one is the corticospinal tract, and the blue one is the medial lemniscus. So usually he uses 5 tracts: superior, middle, inferior, and medial lemniscus, plus inferior cerebellar peduncle, plus corticospinal tract. Finally, I would like to send a special thanks to Professor Abu Zer, our director, and Professor Over Toure, our mentor, for giving me this special opportunity to observe his operations and to do all these nice dissections. This photo last year when Professor Shergil visited us last time. Thank you very much.
Thank you very much, Dr. Moaz, for the nice and excellent presentation on the cross-sectional and surface anatomy of the medulla oblongata. So now we are coming to the audience. Anyone from the participants further ask any question? Any questions from the participants?
I think there's no questions. The presentation today was very clear and very thorough, and we have very nice informations, and we see very nice dissections and very nice pictures of the anatomy. So thank you, Dr. Maab, and thank you, Dr. Prakash, for these wonderful presentations.
Thank you very
Dr.
much.
Shahzad, Dr. Shahzad, please, if you have any final remarks.
No, Dr. Moaz, I loved your presentations, and I really liked the way you used dissection models and how you showed the different white matter tracks on your slides. And I'm very sure that all the students in the audience must have appreciated this. And I would also like to thank Ahmed Saleh for organizing this wonderful activity, Dr. Sohail Ahmed for being the moderator, and of course our two speakers, Dr. Maud and Dr. Prakash.
Thank you, sir.
Thank you very much, Dr. Shahzad, for your nice words. Dr. Sohail, if you have any closing remarks.
I have seen the program layout is very interesting and very informative for the neurosurgeon trainees and the young neurosurgeons regarding the neuroanatomy topics. So I'm very thankful for Dr. Maaz Moman and Dr. Prakash for the nice presentations, and Dr. Shahzad Shami Saab and Dr. Ahmed. Thank you very much.
Thank you very much. Thank you.
I guess if there is no more questions or no comments, we can conclude today's sessions, and see you all, inshallah, next Friday with more presentations and more speakers. So see you all, inshallah, next week. Dr. Shahzad, please, final word.
Yes. With that remark by Dr. Ahmed Salah, we will now conclude this session, and thank you very much, everybody. Please do send your comments because your comments are invaluable in improving our presentations and improving our content. So please do share your feedbacks. So with this, we will conclude our session. Thank you very much, everybody.
Thank you.
Thank you, sir.
Thank you.